Hello, everybody. Welcome to the Decoding Health podcast. I'm your host, Dennis Kamara, and I'm here today with Elina Onitskansky, the CEO of Ilant Health. Ilant Health is a value-based obesity treatment company that's focused on increasing access to obesity treatment while reducing the total cost of care for employers and payers. Elina, thank you so much for being my first ever guest on the podcast.
Thanks, I'm excited to be here, and hopefully this one goes well so that you have many other guests.
Yes, absolutely. So, Elina, I'd love to just dive in more about you. So I understand that you've struggled with your weight in the past, and it played a significant role in why you decided to start a company. Could you share a bit more about your journey with obesity and how those experiences shaped your perspective on weight management?
Yeah, absolutely. So Ilant came out of a combination of my professional and personal journeys. So, professionally, I've been in healthcare, I like to say forever. So I started when I was approximately -5. But, I spent a lot of time working with large established healthcare companies as an associate partner at McKinsey and the healthcare systems and services practice, as the head of strategy for Molina Healthcare. And so, had a very deep appreciation for the system and what it takes to drive value in the system. And, on the other side of my life personally, I've been living with obesity since I was 4 years old. And if there is a diet plan, an exercise plan, a weight loss spa in this country, I've tried it. But more than that, frankly, I got treated at what are considered great institutions, right? I received my care at Cleveland Clinic, Mass General, and Mount Sinai in New York. So these are, certainly very high quality institutions, but I really didn't get evidence-based care at obesity until I sought it out. And so I would say, for me, the aha moment on Ilant is a couple years ago, I quote unquote gave up, right, on the diet and exercise route. I figured if you've done Atkins, Weight Watchers, Noom, and a partridge in a pear tree, at some point you just have to assume that the next sort of weight loss app diet is not going to work. And I actually referred myself into what is considered evidence-based care, in obesity, which is some level of intervention alongside nutritional and physical activity changes. And that was transformative for me. And, I really had an aha moment that obesity felt to me today where mental health was 10, 15 years ago. So I like to say the irony of my life is at the time that I was getting obesity treatment for myself, I was actually working on creating access for others for mental health treatment. And sort of in that moment, didn't actually have the realization that, wow, like obesity is like mental health. And it was only after I'd gotten through my own treatment, I jokingly say the idea for Ilant, came out of a Thanksgiving with my family in Florida, and like all good business school case studies, I was sitting on the beach, looking into the distance, reflecting on my experience, and basically had the aha moment, which is like, I can't believe I hadn't recognized before that my journey was very similar to journeys in mental health and substance use disorder and other sort of highly stigmatized areas that I've been trying to solve. And so Ilant came out of that realization and the desire to solve that pain point for individuals living with obesity, but frankly, in a way that works for the healthcare system, because I deeply believe that the only way we actually succeed in treating something is if it works within the healthcare system and it works from an evidence-based standpoint, from a coordination standpoint, from a financial standpoint.
Thank you for sharing your experiences, and you're totally spot on. I think obesity has moved on from being a fix-it-yourself sort of problem to now being a disease, a chronic disease that needs long-term attention in order for this to be addressed. And I'm curious about your company's name, Ilant Health. It's a bit... It's very interesting. Did you search an encyclopedia? How did you come up with the name for Ilant Health?
Yeah, so it actually came from the Hebrew word for trees. And so trees for me came out of the idea that trees grow, right? And so there's this element of health and growth and evolution in trees that I think is really important, because I do think sort of we want to think about health as a journey and even obesity treatment as a journey right? I think too often we focus on like, what's the number on the scale? And that's not really the goal. The goal is like, what are the things you want to do? Do you want to be able to play with your grandkids? Is there a 10K you always wanted to run? Like, are there things that you want to be doing in your life? So this idea of, growth, health, and evolution. But I think as someone with lived obesity experience, it was also really important to me that growth come from a place of respecting the person. So to me, trees grow from their roots, right? And so I think it's so deeply important to understand where people are coming from. What have been their prior experiences? What have they tried? Where are they emotionally? Because I would say, as someone who's dealt with this across many physicians, I often felt I'd be going into a physician, they'd be like, do you know that you have obesity? Like, have you thought about eating a salad? And I'd be like, I am a woman in my 30s in America. Do you think you are the first person that has observed that I have weight to lose? Do you really think I haven't seen a salad before, right? And so I don't think those people were trying to be not helpful, but I think we fundamentally don't have this sort of respect, right? To say like, hey, I'm trying to be helpful. I want to recognize you probably have your own set of experiences. So to me, it was really like that name encompasses this idea of growth and progression and health, and also respect for someone's journey. What it does not encompass is an easy to pronounce name. So what we've learned is, maybe in the same way that we try to have a personal journey for everyone at Ilant, we've learned everyone has their own personal pronunciation of the name. So we've personalized care in a variety of ways here.
I love that the name so deeply ties in with what you're trying to accomplish at Ilant Health, even if people can't pronounce it.
Cannot pronounce it, yeah.
And I think you've hit on something that's really interesting. There's this sort of guilt or shame that's associated with obesity, and that's something that just affects so many people. When we think about obesity in America, I was surprised to learn that about 40% of U.S. adults are considered obese. And according to the Harvard School of Public Health, that is projected to grow to about 50%. That's a really scary thought. So just from your perspective, what do you think are the main factors that are driving this trend?
Yeah, look, I think the reality is, and there's been these crazy pictures drawn of the like many, many different things that sort of play into obesity. I think there's a whole host of factors, right? There's genetic factors, there's epigenetic factors. So some people are more prone to obesity. Some people have some level of inheritability from their parents, right? So I think there's certainly that component of it. We do know in some sense, and it makes sense evolutionarily, right? The availability of food, right, was not always high. And so the idea that you don't want to lose a bunch of weight and your body sort of hangs on to what you have makes sense. But there certainly are metabolisms in many cases do not work with us. They work against us. That's often called the metabolic set point. And I would say certainly, you compound those genetic, epigenetic sort of like biological factors, obviously with elements of, society today. So challenges around the availability of food, jobs that probably are more sedentary than in the past. And so I think there's, social determinants of health that make certain populations have harder access to food, less time for physical activity, right? Obesity is a huge health equity issue. There is not a health inequality in this country not correlated with obesity. It is more prevalent in Black and brown, in rural, in lower socioeconomic and lower education levels, right? And so there's just this whole compounding. And I think one of the big compoundings is we do know that the body likes to retain weight, right? It is, I am not an evolutionary or a sociologist, but I think that sort of makes sense. And so the idea here is once someone's gained the weight, once they've sort of inherited some of that from their family, very, very hard to sort of lose that without support, without some form of clinical care that helps sort of fight against that very natural desire of the body to sort of stay at a certain metabolic set point. So I agree with you. We're in a scary moment where, a lot of times people say to me, look, we really need to prevent obesity. And I'm like, I don't understand how you prevent something that's here. Like half the population has obesity. If we were hoping to prevent, like the ship sailed and reached the other shore, right? Like we're now in a place where like we've got to treat. Now, I don't think it's an either or, right? Like I think we certainly want to think about also preventing incremental obesity, but I think it's really important that a lot of the ways you do that is you treat, right? You support people with obesity today and also sort of address some of those environmental factors, some of the other conditions that sort of contribute to obesity. So that's a long-winded version there, but I think it's a really complex problem, which is I think why it's so frustrating that it gets sort of oftentimes boiled down to like move more, eat less. I'll say like I was looking, I can't remember even why, but I was looking at a state and they had like probably for 3 decades, like various like plans to reduce obesity, and like the way they were going to reduce it didn't change. So like every 3 to 5 years, it was like more physical activity and more, access to healthy food. The only thing that changed is like every 5 years, it was like, hey, we're at 30% now, we're going to get to 28. And the next 5 years, like they're like, now we're at 34%, we're going to get to 32. But like the way they were going to get there every single time was the same. So I think at some point you have to say like, hey, this is not working, right? Like, let's all acknowledge it's not that we haven't tried diet and exercise before. We have had a whole host of, initiatives around that. It's not working. Obesity is increasing. And frankly, what's even scarier is class 3, or that highest level of obesity, people that are over 40 BMI, is the fastest growing obesity in this country. And so like, we've really got to sort of see the situation for what it is and actually begin to solve.
100%. And you said something that really stuck out to me, and it's that we're trying to simplify an issue that has so many complexities, and that we need to dive in more into the root factors, especially because the obesity epidemic is putting such a financial strain on our healthcare system. According to one estimate from the CDC, the US healthcare system spends $147 billion annually on obesity related costs. And I imagine that payers have a strong motivation to find solutions. You seem to have a pretty good pulse on this. What are you seeing from the payer side in terms of their response in managing costs of the obesity epidemic?
Yeah, so first of all, I actually think the cost of obesity is understated in that 147. But, I hear numbers like that. So the reality is, if you look at claims data and you look at what is the incremental cost for people with obesity relative to someone at optimal weight. And by the way, I like the word optimal weight as opposed to normal weight, because by definition, if one thing is normal, the other things are abnormal. And I think that's all part of this like naming convention. But if you look at people with obesity relative to optimal weight, and you basically say like, hey, if I attribute all of that incremental claims cost that is correlated with obesity, that's over $1 trillion in excess cost driven by obesity. And why is that happening? Obesity drives hundreds of conditions, right? It is literally causal, right, for things like diabetes, osteoarthritis. Like it causes musculoskeletal issues, and it's comorbid, right? With, by the way, it's also comorbid with diabetes, but it's comorbid with mental health. And so if you look at sort of the aggregate impact of obesity, it is a huge driver of excess cost in this country. At the same time, I think the reality is we cannot have a conversation these days on obesity without saying GLPs. So at the same time, right, like GLPs are a very expensive treatment option, and they're growing really quickly. And so I think you see payers coming at this from 3 different areas. On one hand, they really do want to address obesity, and because of the related costs, right? Chronic kidney disease is really expensive. Diabetes is really expensive. Non-alcoholic fatty liver disease is really expensive, right? There are these really expensive conditions, right, that are associated and driven by obesity. And obesity, frankly, makes people harder to treat, right? It's linked with higher complications in hospital stays, greater reoperation. So clearly a ton of cost there. At the same time, in the near term, sort of the idea that we're going to have a large slug of the population going on to GLPs is also just financially non-sustainable. And all of this is also in the context of the fact that both historically and today, there's a lot of concern on the success and long-term or even medium-term efficacy of treatment programs. So the reality is, again, this is not the first time we've tried obesity. You can argue diet and exercise programs not great, but the reality is, we had people coming off programs. Payers are really used to trying other things and having weight regain or poor adherence. We see that with some of the GLP data, right? Where, various sort of pharmacy benefit managers are coming out and saying like, hey, less than half the people are staying on treatment at year one. Now we can all sort of point fingers, right? And say like, oh, it's the cost, it's the bad, clinician, it's, people didn't understand. But the reality is if you look at it from a payer standpoint, or you look at it even from like a population health standpoint, we have a really big problem. We have a condition causing a huge amount of cost. We have treatments that are really expensive that in many cases may not be getting, frankly, allocated optimally. And even for the people on those treatments or other treatments, we're actually not seeing sort of the adherence and the results people want to see. And so I think it's a really challenging moment in time that to sort of say like, how does this get solved, right?
Right, 100%. And it's interesting. I feel like in 2023, the big acronym was LLM, and now in 2024, the big acronym is GLP. And you've hit on it. It's definitely one component of obesity management, but you're seeing a lot of employers that are starting to say we can no longer cover the cost, so we're no longer going to cover this, or saying we're going to put in some sort of requirement that you need to meet before you can have access to this potential life-saving medication. And I would just love to hear your thoughts on this. What needs to happen in order to bridge this access gap? Because it really says now that the only people that can access these types of medications are the people that have employers that are generous, or the people that can actually afford them out of pocket. So how can we make sure we're not leaving anyone behind in the fight against obesity?
So I will say I am a big believer in value-based care. So I think ultimately when you just have a ton of sort of things that feel like they don't work in the system, to me, the goal is align incentives and align the approach. So, in some sense, like what is value-based care? Value-based care is sort of right person on right treatment with right support, right? And so like, I want to break that apart for a minute and sort of talk about like, how does that create value? So I would say let's actually start with right person. So I think one of the biggest challenges is actually the labels for the medications are very broad, right? So the label for every single obesity medication is the same. It's what we call a class label. And that class label is basically for anyone who's 30 BMI or above, which is anyone with sort of class 1 obesity or above. And it's also for anyone sort of overweight in the 27 to 30 BMI camp with some comorbidities. The reality is, and by the way, that's the medication labels. Bariatric surgery is also indicated, depending on who you are, for 40 BMI and above, or 35 with a comorbidity, or 30 BMI with diabetes, right? So we have a host of medications that overlap. Bariatric surgery overlaps, and certainly like, you could say, cognitive behavioral therapy or lifestyle modification is indicated for everyone, right? So we have a ton of overlapping treatments that essentially say like for just about everything, about half the population qualifies. Well, the impact of obesity varies a lot, right? So someone at 40 BMI, right, like their likelihood of diabetes, of obstructive sleep apnea, of musculoskeletal pain is materially higher at a population level than people in the overweight or class 1 obesity category. So I actually want to, by the way, split here the concept of population and person. So an individual at 30 BMI may have a lot of impact from obesity, and an individual at 45 BMI may not. But when we look at a population basis at sort of the whole US, or the reality is people over 40 BMI, more clinical problems, more cost as a group. And so I think that is just, so as you think about like, hey, where is there the greatest value from treatment, and value here on clinical outcomes, on financial cost, on quality of life, it is skewing towards those higher BMI, higher comorbidity groups. I would say the real challenge here is in highly stigmatized areas like obesity. I would say the sad irony is that the people that actually have the greatest impact from disease are often the least likely to seek care. We saw this in mental health. We saw it in substance use disorder. Why? Because people at lower acuity levels have historically passed, right? They're the people who maybe were struggling, but when they went into a clinician, they weren't sort of quizzed on if they'd ever heard of a salad before, right? Maybe someone's like, hey, and like, if you can, like, think about like, staying healthy, right? And so like those people are actually don't have the same sort of feeling on like, hey, I'm not going to be supported by the system. Maybe this won't work for me. And so they actually go and seek care first, right? And the people that we really want to support from a clinical standpoint, a quality of life standpoint, a cost standpoint, may not seek that care. And so I think it's really important to have a proactive strategy around engaging the quote unquote right people, right? Making sure that the people who need care the most, right? In some sense, if everyone was passing through an ER, the folks we triage for care first are really getting that care. In obesity, that need to sort of supply people care is further compounded by the fact that we haven't treated obesity as a disease. And so it's really poorly coded. So obesity, 40 to 50% of the country, about 10% of it in claims. And so if you are sitting at a employer in a health plan and you're saying like, I really want to help people with obesity, you actually often can't find the people who need care the most to proactively engage them. And so there's a lot of focus here needed on, frankly, the analytics to identify. So, by the way, that's some of what we do at Ilant. We run in a lot rapider terms, claims analytics engine, where we basically use a lot of the other factors to say who has likely has obesity and needs care and support. And then really having a way to engage individuals in a non-judgmental way so that they sort of feel like, hey, yep, last 5 times I engaged with the healthcare system, it was terrible, but this is going to be different. I'm actually going to get care. So that piece one for me, like right people, let's get to the people who need care the most. Higher acuity, often correlated with higher BMI, not always, but really important. We're sort of accessing people with higher need. Second piece is that right treatment, right? So I'm not saying we don't need to treat across the board. Obesity, obesity does affect people at class 1. It affects people at overweight, especially, by the way, in a society where, there is a lot of ongoing discrimination and stigma and bias associated with obesity. But we need to make sure that we're aligning the treatment to both the severity of disease and, frankly, to what's most likely to work for the member. So, when we think about treatment, there's so much focus on weight loss. That's important. As we just talked about, weight is associated with higher likelihood of many diseases. However, what we should be focusing on in some sense even more is remission or reduction in existing conditions, right? If you have diabetes, how do I think about most impacting that disease? If you have high blood pressure, how do I think about getting you, reducing some of the impact of that hypertension? If you're having knee pain, what's going to drive that? If you're on a CPAP for obstructive sleep apnea, what's most likely to sort of support you there? So to me, it's really important that we think about the right treatment matching. And that is naturally going to mean that it's not GLP-1s for all and GLP-1s for none. And look, I think where we then want to evolve that is, how do we think about the biomarkers and the phenotypes? So there's, I think, tens of drugs coming out in the market. There are new surgical innovations. What we need to start thinking about is, how do we match people to the treatment that's most effective for them, starting where we are right now on sort of an acuity weighting basis, but actually really moving towards personalization. And just to put in the pitch here as well, that's the Ilant Metabolism Matter. So we focus on that piece there. And then, what I like to say is none of that matters if you're not I got the right person, I put them on the right treatment, they quit after a month. This will be a shocking comment. That's not going to work. We actually have to support people on treatment. And so I think one of the challenges here is, access to clinicians that really know this space. And I mean, board certified obesity medicine physicians, but also, frankly, registered dietitians who know how to support people with, obesity, that are on anti-obesity medications or bariatric surgery. It's mental health specialists who actually are familiar with eating disorders and cognitive behavioral therapy for obesity and also know how to clear someone for treatment, right? We need to get the right support in place, and we need to do that in a non-judgmental way, right? So to me, peer-based support is going to be really important here, not because clinicians are not well-intentioned, but because a lot of people in highly stigmatized areas, have some level of distrust, even for the most well-meaning clinicians. And so for me, it's how do I treat people in the right way, but then also how do you support treatment longitudinally? And longitudinal treatment is going to be that right care team, that right peer-based support, and frankly, also leveraging technology to figure out when is someone struggling. So, when I started out at Ilant, I sort of talked to, clinicians because there was a lot of concern around weight regain. And I would sort of ask physicians, well, why did these patients regain the weight? And they're like, oh, they stopped coming to appointments. And I was like, well, do you think that was maybe a signal that we should go proactively engage them? And people were like, sure, but there's only so much time in the day, right? So one of the things that happens, right, when you're living with obesity is so often people tell you it's your fault, right? You lost 30 pounds and then you regained 2 pounds. What did you do? Did you eat that piece of cake? Why would you eat cake? You just lost 30 pounds. And so people are so ashamed that you regained the 2 pounds and you're like, I'm not going to see anyone until I've lost the 2 pounds. But the problem is you don't lose the 2 pounds. You gain another 5 and then another 10 and another 15. And then you're like, well, I'm definitely not going in now. I'm I've regained 20 pounds. And so the reality is how do you both make it okay, right? And you say hey, people regain 2 pounds. It happens, right? You're human. I'm human. Let's sort of go where we are. And how do you actually also proactively monitor? So you notice when someone stops coming to appointments, you notice when they stop engaging and sort of say hey, those are signals that someone needs more help. That's actually the moment in time not to engage with them less. That's the moment in time to engage with them more, right? And so to me, it's incredible that we have GLPs and bariatric surgery, by the way, safest surgery out there. We now have tools we didn't have before, but those tools only work if they're deployed effectively. So Dennis, you may have gotten way more than you wanted there, but that's a very simple solution to the obesity epidemic.
I appreciate how comprehensive that was. And you hit on so many different gems. The one area that I'd love to hone in on more is you talked about this idea of patient engagement and how those who are the most at need for treatment and support are often the ones that are disengaged in the process. And obesity care is becoming so increasingly competitive. We're seeing a lot of startups that are coming in. We also see a lot of legacy companies having to reimagine what their offerings are. So when it comes to patient acquisition, how are patients discovering and connecting with Ilant Health?
Yeah, so our focus is working with employers and health plans. So I think one of the ways is, we'll contract with an employer health plan, and then we will jointly share information. So that might be mailers, that might be emails, right? That might be, on-site, days to learn more. But that's sort of the tactics. I think what's really important is the messaging, right? So we are really, really conscious of the words we use. We are so deeply focused on being non-judgmental, right? We are not going to tell you about you, right? We're here to support you, right? We're going to help you understand treatment options, but we're the roots of that tree. We recognize there's a journey. We're going to try to understand that journey. We're not going to prescribe you one diet plan, one exercise plan. The treatment that works, the diet and exercise plan that works is the one that you're going to do, right? It's got to fit into your life. It's got to be culturally competent, right? One of my frustrations was you'd look at sort of quote unquote, recipes for healthy eating and they didn't there were nothing that you would say oh, here's what a Hispanic person might want to eat at a family dinner. Not saying, someone who's Hispanic doesn't also want Indian food but you want to make sure that people are able to sort of feel like this is something accessible to them, right? That it fits in with their family meal, right? Like, and so I think it's really important, non-judgmental, culturally competent. And I think you've got to build trust, right? So ultimately, this does come down to trust. And because you're saying to someone basically, like, I know it's been terrible before, trust us. We're going to do better. Trust us. We're going to help, right? That is a really important part, by the way, of getting people to access treatment. But I think it's also really linked to this idea of how do I actually get people to trust me that when I tell them, hey, you could be successful on intensive behavioral therapy, you might want to consider surgery. You are someone who might be really successful in Kissimmee, or actually, I do think a GLP-1, even though you might be worried about some, how do you build that trust? And so for us, huge part of that is non-judgmental language. Other part of that is that peer-based support. So at Ilant, the first person someone interacts with is actually someone with lived obesity experience. We call those peer navigators. But the idea is like, they are not going to judge you. They've been there, right? They really understand what is it like to walk into a store where they literally don't sell clothing your size, right? Like, what is that like? What does that feel like? What does it feel like to have a clinician who's like, oh yeah, like I totally have the answer for you. It's salad. And you're like, thanks. So I think that's a really important part. And it's also really important. We celebrate wins, but we also, we don't judge quote unquote losses, right? We're there throughout the journey. So I think that's a really core part of engagement. And look, I would say we'll see where things land, but especially folks pivoting into the space, I see a lot of like, we are incredibly good at hypertension and therefore we can address obesity. And you're like, hey, like, would you say like we're really good at physical health and therefore we're great at mental health? So I think there's got to be like a baseline respect, right? I get it. If you're a company in the space, obesity treatment's really exciting. You're like, hey, here's this massive market. I can make so much money, right? Like, but the reality is there's humans here, right? There's humans who've had terrible experiences who want respect for that experience. And so, I would say as a person living with obesity, I hope that my quote unquote competitors offer that respect. Maybe as a competitor in this space, maybe I hope they don't, because I think that will lead to their failure. But who knows? But I think there's a core element here around, just sort of going out. I think there are a lot of companies that came out on World Obesity Day with like, oh man, obesity is a disease. Like, yes, good. Very helpful, but like, do you really understand what that journey and that experience has been like? And can you engage with that, right? Not just, by the way, not to go the other side of the house, which is the direct to consumer, like pill mill, we're going to write the script you want, but can you actually engage in that experience and still have a sort of counseling approach where you support members in great care?
It's really cool that Ilant Health is creating a space where people feel like they can open up and be vulnerable about things that are so personal to them. I mean, when you think about it, being vulnerable with someone is what really allows you to build trust, right? It's like when you feel comfortable sharing your deepest fears or struggles with someone, it creates this bond that's hard to break. And that's exactly what you need when you're dealing with health issues like obesity. You need to be able to trust your healthcare providers and feel like they really get you. So, yeah, I just think it's really awesome that you're leading with empathy and making that a priority at Ilant Health. It's a really special thing, and I'm sure it makes a huge difference for patients.
Give you, Dennis, one, maybe two vignettes that have been really meaningful to me. So one, for one of the small employers we're supporting, we had one of the members go out and start a Slack channel about Ilant because she was worried that this will shock all HR leaders, that people may not read HR communications and that therefore may have missed the announcement that this program was being offered. And to me, as someone with that was so deeply meaningful because she went out to her coworkers and basically self-disclosed, right? And said because she was so passionate in making sure that other people had access to treatment. And then, the other interesting vignette for me is as I engage with various employer leaders in particular, what's interesting to me is, we'll be in a room and someone will come up to me afterwards and say like, hey, really appreciated you said that. Like, I'm on treatment and here have been my challenges, right? Like, and so I do, it's interesting because I mentioned at the beginning of this that mental health, those were the stories we used to hear about mental health, that mental health companies would pitch to an employer a health plan, and then someone would get an email from a personal account that basically said like, hey, thanks for doing that. Like, I've struggled with it. And so I think, that's a really big piece of what we believe is important to be successful in this space. You've got to access that lived experience element and be able to sort of engage there.
100%. We're going to move into our rapid fire questions.
All right.
Feel free to answer with the first thing that comes to your mind. What's one area in healthcare that you believe is overhyped and one area that you think is underhyped?
Yeah, so I'm going to say in overhyped, it's direct to consumer or consumerism. I actually think there's a very big difference between being member oriented and personalizing care and being direct to consumer. I really deeply worry about, that trend. And frankly, I think we need to get better as the healthcare system in supporting members. The answer, though, is not to have everyone go around the system to sort of, in the worst case scenario, like asynchronous text-based prescribing. So that, to me, very hugely overhyped. Obviously, tons of investment dollars around that. And, I don't think that has solved access, shame, stigma, or quality care in most cases. Underhyped, I actually think transparency. So, obviously, like when we think about what is needed to engage people in their care decisions, I think it's transparency of information and accessibility, like both price transparency, but even like personalization of information. What does a treatment mean for me? What are my risks? What is this literally? What does this mean for me? And so I think, I'm like, if you think about that, like, how do we make healthcare more personal and more consumer oriented? I think we've gone the wrong route. We've gone like straight to this like D2C, like fast scripts. And what we've missed is like actually that personalized information that would enable that. So that's
Period.
the slightly not fast take there.
No, that was perfect. Outside of work, what's one hobby or activity that helps you maintain a healthy work-life balance and recharge?
Yeah, so I'm a huge fan of the theater and the arts. It's one of the reasons I love living in New York. So you can often find me exploring an art museum or going to plays. So that's a big, I think maybe that's just a different part of my brain that gets activated, but I enjoy that a lot. And then I would say the other piece is during COVID, I picked up walking Central Park. So I think I must have walked just about every path in Central Park, and that's still just a great way for me to decompress.
Oh my God, I love being able to just get outside. And in terms of the theater and the arts, are there any movies or TV shows that have really engaged you over the past year?
So I'm not, I would say TV shows and movies I sort of watch to like, not think. But yeah, I would say, maybe this is not a recent one, but this is one of the few actually Broadway shows I've watched a couple times, Come From Away. It's actually about that Newfoundland community that sort of supported planes landing during 9/11. It's a very like inspiring on human beings, like acting the right way and supporting each other. So like, that's a very uplifting one for me. But other than that, I actually like sort of small plays. A lot of what the Beaumont Theater at Lincoln Center produces, I'm a huge fan of. So yeah.
I haven't heard of that play before, but I'll definitely have to check it out. I really like the idea of communities coming together and uplifting each other, especially after tragic events. Last rapid fire question. What's the most important lesson you've learned throughout your career?
Probably, I would say just the importance of grit and sort of, linked to that sort of a learning mindset, right? So I'm actually a really deep believer in data and analytics. And I think that links really closely to this constant idea of learning and evolving. So, I sort of, at any moment in time, we talk a lot about in healthcare evidence-based care. And I think sometimes people forget evidence-based care evolves. And like our role, I think, as leaders in the space is to really constantly be pushing to learn and grow and evolve and sort of increase our understanding, I would say, as individuals, but as sort of companies, as systems. So I'm a big fan of sort of grit and lifelong learning.
Grit is always super important, especially in founding a company. And that leads me to my last question. Your career trajectory is just very impressive. You worked at McKinsey for over 7 years, and you rose to become an associate partner. And you eventually became the senior VP at Molina Healthcare before founding Ilant Health. So, as someone who's successfully navigated the corporate world and made the transition into entrepreneurship, what advice would you offer to others who are interested in becoming founders themselves?
Yeah, so, look, I think obviously, one of the big challenges coming from large companies to a small company is like you have less resources and your cycle time's much faster. So I think you really have to be thoughtful around that. But I think taking a step back, I think in any role, what's important to really understand is like, what do you know well? What do you not know well? And how do you actually have the right, whether it's team members or learning or support structure to address the things that you sort of don't know well. So I think, maybe it links to like, I always think of things as learning, right? Like, how do you basically understand what you know, understand what you don't know, and, learn what you don't know?
Well, that's 100%. You don't know what you don't know until you learn and find out. Elina, thank you so much for being my first guest on the Decoding Health podcast.
Absolutely. I enjoyed our conversation, Dennis.
Thank you again. Until our next decoding session, take care.